If you have a recipient, a maternity patient, who delivers prior to October 1st, 2019, all you would do is you would bill your maternity contractor like you always have, unless you're in District 10 and 12. For District 10 and 12, you would just submit a fee-for-service claim. On or after October 1, if you have a recipient who has delivers, you do not need a DHCP referral from an ACHN, because ACHNs will not be issuing referrals until after November 1st. All you have to do is submit your regular claim fee for service, and it will process. After November 1st, when the ACHNs are providing care coordination, so let's say, for example, you have a woman who delivers October 20th, but you want to see her for postpartum visit. Well, to be reimbursed for that postpartum visit, you will need to have a ACHN referral number, so you will need to reach out to the ACHN. So we just want to review that, because that seemed to be a confusion for a lot of people. If you have any questions about anything regarding ACHN, billing, DHCPs, PCP participation, equality bonus payments, cost effectiveness bonus payments, attribution, anything like that, please, we encourage you to submit it in the chat box. That's the whole point of today's webinar, is just to answer any additional questions that we might have. All right. Go back a couple slides, because I know we've had a couple people join. We want to go over the participation requirements. Again, we have the different agreements that you must sign. For a PCP, you must sign the primary care physician group agreement with Medicaid and a participation agreement with PCP. You must also participate and be actively participating. To be an active participation, you must work with an ACHN to review recipient care plans. You must participate as needed in any multidisciplinary care teams. You must participate in ACHN initiatives centered around quality initiatives. And you must attend at least 2 quarterly medical management meetings and 1 webinar within a 12-month period. Now, nurse practitioners and physician assistants may attend for a PCP, and it's only 1 provider must attend per group, as well as you must also review any data provided by the ACHN. All right. As we still don't have any questions, we'll continue on. So we also wanted to cover our BMI reporting. Jerry?
Okay. First of all, I want to let you know that pregnancy diagnoses are excluded from the BMI requirement. And we have heard feedback from several of you, and we've taken it into consideration. As a result of this feedback, we're making a slight modification to ease the requirement on BMI coding. BMI coding will still be required on each claim. However, the same BMI can be reused until the next well-child check, where a BMI is typically determined, or sooner if the physician feels there's a clinical need for a BMI redetermination. We will be monitoring the issue over the next year, and since we're so close to go live, a major modification would not be reasonably feasible. For those recipients that are wheelchair-bound and it may be difficult to obtain a BMI, an override may be requested. Send those override requests in to managed care for reconsideration. The ages for the requirements are for children ages 3 to 19 and for adults age 20 and over.
All right. Patient first versus attribution. We kind of wanted to go through the examples and talk about what is the difference between patient first panels versus attribution. First of all, I hope everyone's aware that patient first will be ending September 30th. There will no longer be patient panels, and PCP referrals to PCPs will no longer be required. Again, if you are primary care and a recipient comes to you, you can see them without a referral. If you're a specialist and you need a PCP shows up to your office, you do need to have a referral. Attribution begins October 1st, 2019. Attribution is a process where we'll be associating a Medicaid recipient to the PCP group that provides primary care. So basically, the big difference is where patient first panels were a prospective assignment. You were assigned patients for this coming month. Attribution is retrospective. We evaluate all of the care that is provided to a recipient for the past 2 years and evaluate who of those who provide the care or should be the patient be attributed to. Who has provided the most care? All right, we have received a question. If a Medicaid patient sees a nurse practitioner for a gynecological appointment, will they need a referral? We're required to receive a referral today.
Yes, and if your group is enrolled as a delivering healthcare professional, then you will not need and you're part of that group and you're tied to that group, you will not need a referral.
And that is for not a well woman visit, correct? That's for something a more maternity-related issue. That's when they would need a referral, correct?
They will not need a referral going forward.
Good. Any other? If you have any questions, please enter them in the chat box. All right. Next slide. All right. Melanie?
Good afternoon. If you are looking for information about the Alabama Coordinated Health Network, there are different pages that I'd like to refer you to. Of course, you've already seen the ACHN provider tab, and it has all the information you need for finding these webinars, finding out information about the provider billing manual, just all different tabs for you as providers. But if you are speaking to recipients who may have questions about the ACHN, of course you're going to gear your conversation a little bit differently because they don't need to know the same information you do. So I want to encourage you, if you have not already, to visit under the ACHN tab. There is a separate communication tab for recipients. Visit that and you'll see about a 6 to 8 minute video posted that gives an overview to recipients who would be affected. And there's also some handouts that you could print and put in your office, specifically one for maternity, one for our patient first population, and you'll see that one referred to as general Medicaid population after October 1st. And then the third population, of course, is planned first. So we have targeted communication for each of those groups with handouts, and I encourage you to go and print those out and put them in your office or public spaces for your recipients to find out more information.
Okay. We have a follow-up question, Jerry. Just to confirm, for a problem GYN appointment with a nurse practitioner, is a referral needed?
No.
The answer is no. If any PCP can give a referral to a specialist, how are the specialty clinics going to determine who to call? I think they will automatically call the attributed provider, which may not be the referring provider. Any advice on what we can tell these offices when they call? Yes. If a specialist needs a referral, we would encourage you to the provider portal and see who the patient has been attributed to. If you know that provider to be a primary care provider, you can call that provider. If the recipient, you can also call the recipient and say, who is your primary care provider, and they can get it. And if they don't have one, that is when I would encourage the specialist to call the ACHN, because that is one of the jobs tasked with the ACHN, to encourage them to have a medical home and find a primary care provider. Would we consider publishing some guidelines for those specialty offices and provider types will continue to require a referral?
We are releasing our provider manual at the end of this week, and so there will be more details in the provider manual, just as there are in our Patient First chapter today. Some of those would be provider type related, and some of them are service related. So you'll need to really, really dig into that provider manual and see the details.
What if we did not refer to the specialist and the patient is attributed to us? Who should send the referral then? If the primary care provider, if a different primary care provider sent the patient to the specialist, that primary care provider should be the one who sends the referral. You have the ability, though, as the patient's been attributed to you, and if you're the primary, generally the primary care provider, you can also submit a referral. Again, if there's any questions, please enter them in the chat box. I think it is important that the specialty providers understand what referrals will be valid.
If you have a valid referral, if you have a referral today, your referral will not end until the date on the referral ends, so it would still be valid.
We just started the webinar. We started about noon. You haven't missed any presentation if you have just joined us. The whole point of today's webinar is to simply ask, to answer any questions you might have. There's a question in here for you, Jerry. There will be confusion in the beginning as to which PCP referral they can accept. You want to talk again more about the patient?
A specialist can accept a referral from any PCP.
So it does not matter what primary care provider submits the referral. Any PCP can submit a referral. It does not have to be the one they're attributed to. There won't be an assignment. It could have been, they could have seen a PCP for the first time ever last week, and they send you on to the patient on to a specialist. That PMP can submit a referral. To be clear, no referral is necessary for OB, GYN, or well woman care at an OBGYN office, correct?
Yes.
That is correct.
Correct.
So a claim will not deny for specialists as long as a PCP is listed on the claim.
That's true.
That is correct. What does a patient need to do if they deliver in October? Let's go back a couple slides to the chart we had. Here you go. If a patient delivers in October, that delivering care provider, all they will do is submit all claims. They'll submit that delivery fee for service to Medicaid. That DHCP will not need a referral from the ACHN. All the patient needs to do is show up to the hospital to deliver. Let's see. As a therapy clinic, we have a patient that was referred to.
But they did not send an EPSDT because of full Medicaid.
Also, the patient is living in Marshall County, but shows Shelby County as address. Will I need to contact ACHN or referring doctor for EPSDT referral?
The referring doctor. Be the referring doctor. And that was
so you would need to contact the referring doctor because they need to complete the EPSDT. Question about the different addresses, whether they're living in Marshall County but the address shows Shelby County, go with the address that is on the eligibility file. The address that is on the eligibility file is what the agency used to assign recipients to a ACHN. So for that one, call Alabama Care Network Mid-State because they're the ones who, for Jefferson Shelby County. Can any PCP provide an EPSDT screening?
as long as they're enrolled as an EPSDT screener, yes.
So as long as you're enrolled, you can as an EPSDT screener. Some of us providers will not feel comfortable sending referrals to specialists for issues that we are not aware of or maybe do not agree with. Would the appropriate action to be to direct the specialist to contact the ACHN, and will these patients be directed to follow up with the referring provider with any questions or problems related to referrals or procedures resulting from the referrals? If you are a primary care provider, that is part of your agreement with the agency to handle all medical needs. So if you, under your medical judgment, believe that you need to refer a patient to a specialist, it is your job to refer them to a specialist. What reports will be provided to the attributed provider? Will the report show what information is missing for the recipient? Okay, let's talk about a couple of reports that we're providing our providers. Just like you currently at the beginning of the month get a series of reports under Patient First, you'll still get, instead of a panel assignment report, you'll get an attribution report. It is the agency's intention you will have around the 1st of October to have the first attribution report. You will see 3 sections: newly attributed patients, and patients who have lost attribution. Those 3 sections will not be filled out this first time. You will have who's been attributed to you, but the changes won't occur because this is a first run for everybody. Moving forward, the last month of the quarter, you will see, so again, in 1st of December, you will receive a new attribution report when the agency runs it again, and you will have that. The EPSDT screening report will still be provided to all providers. Yes. For those of you who called in, were not able to originally log into the webinar, but were able to call into the number, a new link has been posted on the Medicaid website. Select the web slider and click on the new link. That would be the big giant banner up at the top is a web slider to access that option. All right. Some specialists were told to disregard old referrals given and start with new referrals beginning October 1st. Is that correct?
No. If you received a referral from your PMP prior to October 1, it's still valid. It only ends at the end date that is on that referral.
And kind of following up with that, since a lot of specialty candidates may not be watching this webinar, will the agency publish something online that states existing referrals is still valid and how long it's been? How long ago?
This question came in as part of our FAQs, and it will be posted online.
Okay. You can see the chat, but nothing else is open. That's all you should. You might be having connectivity issues. We are sharing some slides, but if you have any questions, you are able to type them in the chat box. Do OBGYNs have to send referrals to other specialists?
OBGYNs can send referrals to specialists because for a lot of our recipients, they consider the OBGYN their PCP. So we are allowing the OBGYN beginning 10/1 to be able to send a referral to a specialist. Today they can't do that. The recipient would have to go back to their PCP. But in our new world, the recipient could get a referral to a specialist from the OBGYN, but they don't have to. If the OBGYN is not comfortable with that, then the recipient can go back to their PCP and get a referral for a specialist.
As a facility patient, patient is referred to specialist. Does that referral cover the facility? The referral should cover the facility. If the patient is being referred to you, for an example, you're a radiologist, the patient's been had for an EKG. Well, as the radiologist who's performing the EKG or reading the EKG, they would be covered as normal. Yes, the Q&A, this webinar will be posted like we have. It's being recorded and will be published later today along with a few slides that we have. A lot of the question and answers we've asked have also come through our web portal, and we have been updating our FAQs, and all the answers have been answered. Can you list the BMI code as a primary diagnosis, or does it have to be secondary?
It can be either.
Okay. Any other questions anyone might have? All right. When referring a patient to Children's Hospital, can we list Children's as a consultant and have this referral be valid for all providers of children that the patient may see at cascading?
They can do it.
Okay. Let's see.
That's
Prudence, we're going to follow up with that question. If you could email that question about referring to Children's Hospital to Beth Huckabee at the agency, she'll respond to you on that one. Is it no longer required that a referral come from the PCP listed in the Medicaid system? That is correct. Any PCP may submit a referral. A patient has freedom of choice to see whatever PCP that they want to. The provider that is listed on the Medicaid site, the web portal, will be the provider the patient has been attributed to. That does not necessarily mean that was their current PCP. It might not be the one that they've chosen to see last. It is just based off of the historic utilization, who the agency has attributed that patient to. If the patient has an EPSDT referral good through November, but their EPSDT was done 9/23/18, will the patient need to wait until October 1st for an updated EPSDT since the patient's first doctor is no longer in the area? If the patient has an EPSDT referral good through November, but their EPSDT was done 9/23/18, will the patient need to wait until October 1 for an updated EPSDT since the patient's first doctor is no longer in the area?
The EPSDT would still be valid.
Okay. If an OB patient has other primary insurance and Medicaid secondary, does the initial prenatal visit have to be billed to the primary insurance for denial before being billed to Medicaid?
Yes.
Yes. NCQA approved. Do we have to report to Medicaid to be eligible for NCQA bonus? Yes. At some point, the agency will be putting out, some point in the next couple months, the agency will be putting out additional guidance. The first year, all PCP providers who meet participation requirements will be eligible for all three bonuses. After the first year, we will start paying for performance. The first one that goes into effect is the PCMH recognition. If you currently already have NCQA accreditation as a PCMH, you would have to provide that documentation to Medicaid. The agency will be providing additional information in the provider manual as well as alerts and additional information on how you would have to report that. But yes, you would have to report that to Medicaid on an annual basis. What is the official Medicaid guideline for the definition of first trimester? 0 to 13 weeks or 0 to 14 weeks?
0 to 13.
And it's 13 weeks, 6 days. There's a very distinct, that we have answered that in the FAQ. It's a very specific definition we put out. It's on the FAQs. I believe it's like 13 weeks and 6 days. Some recipients get their EPSDT screenings prior to their birthday during any calendar year. How will this affect the scoring when trying to close gaps in care when the recipient can only have one per calendar year? Some recipients get their EPSDT screenings prior to their birthday during the calendar year. How will this affect the scoring when trying to close gaps in care when the recipient has only one per calendar year? So that really should not be an issue because all quality measures are evaluated on a calendar year. So that's one reason why the quality bonus is the last one to be calculated to go in, because we will be evaluating you on the calendar year 2020 performance, which we'll start paying in calendar year 2021. As long as we have had a well child visit in calendar year 2020 for that child, you will be fine. You will be counted and you will meet the measure specifications.
If the child is attributed to that practice.
As long as that patient is attributed to your practice. All right. Any other questions?
There was another one, Drew.
Isn't the EPSDT referral good for a year from the date the EPSDT screen? So a 9/20. Jeff Huckabee with our provider program will answer this.
Hi, this is Jeff Huckabee. Whatever you are doing today for EPSDT will continue, so please continue as you are doing today.
All right. Mandy, why don't you go to the slide where we talk about the communication stuff? Just let me put that up. All right. Again, we just want to make sure y'all all have these websites. We have updated the website in the last couple of weeks. There's a lot more additional information out there for recipients and providers. We do have some handouts and a copy of the letter that has gone out to all of our recipients that any provider may print and put in their office if they want to provide additional information to their patients. As of this point, ACHNs will be going live October 1st. The agency has seen no issues with anything with readiness. We've completed readiness. So all 7 ACHNs will go live. Patient first has already been slated and everything's taken care of, along with the maternity program, 2N930. Please talk to your associates. Talk to your colleagues. If anyone has this understanding that the ACHN will not be going live statewide October 1st, that is incorrect. ACHN will go live October 1. Will there be a certain form to use when we ask for an override on wheelchair-bound recipients? Should we submit the claim and get a denial first? First of all, just because a child is in a wheelchair does not automatically guarantee we will allow an override for BMI. BMI still needs to be provided for all children. We would ask that you submit a request for an override if the child for some reason could not be weighed. Just being in a wheelchair is not allowed. All of our providers have, as they enroll in Medicaid, agreed to provide and be ADA compliant. If the child just cannot be is unruly, is out of can't be controlled because of some condition, those are the type of the information the agency would need to have. But we're not just summarily waiving the BMI requirements.
And I will say, this is Jerry Jackson, Form 391 PCP Override Request Form, and it was revised in September of 2019, is on the website under PCP ACHN Forms. And so you can go to the ACHN tab, go to Provider, and then go to the Forms.
All right. We're still waiting for any additional questions. And if we don't receive any couple minutes, we will go on in the call. Melanie, did you have anything you want to add?
Yes, I just wanted to add, if you're looking for the contact information for the ACHN, you can find that specifically for your contacts for providers. We do have it distinguished for you and as well for recipients. Under the ACHN providers, you'll see both the executive director and email address for a direct contact to the ACHN, but this is only for providers. If you go to the ACHN recipients page, there is contact information, a 1-800 number that will be live starting on October 1st. There also will be links on October 1st available directly to the ACHN entities. So that information will all be uploaded and made live October 1st.
Yes, we understand that the webinar has been, we had slight technical issues this morning starting it. There really haven't been any slides. We only have 5 slides and we will be publishing them. They are summary slides from each of the, and we've actually taken each of the slides from previous webinars. The whole point of today's webinar was simply to ask any additional questions and answer anything that you might have that we might not previously have covered. So if you have any questions, we are open to taking them now. But for those of you who have joined us late, we are recording this. We will put up the 4 or 5 slides that we have up there, but they all have come from previous presentations. All we have covered, when not answering questions, has been just kind of additional things that we have covered previously in the previous webinars. We have not added any new information. Again, if you have any questions, please enter them in the chat box. All of the questions that have been asked and answered on any of the webinars, you can respond back to any of the webinars and listen to the recordings, just like this webinar will be posted, as well as most of the questions that we have received through all of our webinars have also been entered in through our web portal, and we have answered those and posted the answers on the website. Not every exact question, but most of them that are very similar to them. For ER visits, what is required?
For ER visits, if the ER visit is not a certified emergency, you will still be required to have a referral from that PCP.
All right, as we have no more questions today, we'll go on and end the webinar and give everyone back 15 minutes of their lunch. We do want to thank all of our providers who have sat through all of these webinars. I think we've had some great questions that have come in. Hopefully everyone understands the ACHN project and what's expected and what's changing with providers very soon. But at the same time, we also want to make sure everyone's aware that the ACHNs will go live next Tuesday. The attribution process will begin. Attribution reports should be in everyone's web portal Monday at the latest. Thank you very much, and have a good day.